everyone. If I could get your attention, please. We're about to get started. Thank you for coming today, and I'd like to introduce Santiago Caraballo, who's going to give our opening remarks for today. Thank you.
Good afternoon, and welcome to the Baker Institute's presentation on how Obamacare might change in 2017. My name is Santiago Caraballo, and I am the Senior Commercial Banker at Bank of America Merrill Lynch, leading our coverage of not-for-profit healthcare institutions in South Texas and Louisiana. Bank of America Merrill Lynch is a leading provider of services and capital to the healthcare industry, with over 3,000 clients and over $36 billion in capital commitments. I have personally worked with the healthcare industry from a capital finance and financial services perspective for over 12 years, and have worked with many of the leading healthcare systems in Texas, Louisiana, New York, New Jersey, and Pennsylvania. I can attest from firsthand experience to the impact that regional, political, and economic factors can have on healthcare providers. But few, if any, developments have impacted the industry more broadly than the Affordable Care Act. 3 years ago, I was fortunate enough to discover Dr. Ho's work on the Affordable Care Act. And since first attending this presentation, I've been a close follower of her research and ultimately a supporter of the Baker Institute's Health Policy Forum. Today, it is my distinct honor to introduce Dr. Vivian Ho to you. Dr. Ho's formal biography is in the program at your table. In addition to that information, I'd like to add that Dr. Ho has been actively working with her colleagues at the Baker Institute and elsewhere on a variety of health policy issues this year. Those projects include the spread of freestanding emergency departments in Texas, the quality of care in safety net hospitals, and the implications of hospital-physician integration for hospital quality and costs. Many of you are also aware of Dr. Ho's partnership with the Episcopal Health Foundation to report on the evolution of the Affordable Care Act in Texas using the Healthcare Reform Monitoring Survey. That work in particular has enabled Dr. Ho to become an expert on health policy reform at large. We are delighted today that Dr. Ho will share her insights on what health policy reform could look like in the U.S. after the fall presidential elections. Now please join me in welcoming Dr. Ho.
Thank you, Santiago, for that kind introduction. And thank you all for coming here today. I know it's kind of risky on such a rainy day, and we hope to, we've got you in dry, and we're going to get you out dry, we hope as well, if the weather cooperates. You know, I wish I could take credit for everything that happens today, but I really can't. This is a team enterprise. So first of all, we're very grateful to the Health Policy Forum members who provide us the support and guidance that allow us to come up with the material for this conference and for the other events and research projects we're working on. Also, I'd like to thank two members of the Center for Health and Biosciences, Brenda Laymans and Mara Short, who did a lot of the legwork in terms of getting the material for these slides, the research background, and also putting them together. And our events staff is just terrific, Melissa Griffin, and then the audiovisual people backstage. It's very inspiring to see how much the Texas Medical Center is getting involved in health policy lately. If you're interested in much more health policy in general, I can recommend the Baylor College of Medicine Health Policy Symposium, which is on Saturday, June 11th, and Elena Marks, our non-resident fellow, will be speaking at that event. That's at the McNair campus, and I believe there's a poster out front talking about that. And also the TMC Health Policy Institute is organizing a symposium for the fall. That hasn't been confirmed, but please keep an eye out on that. So let's get to Obamacare and what it could look like in 2017. I don't have a crystal ball. I'm going to sort of do the best I can, and then you can all sort of think back once you're, before the next luncheon talk this time next year is like, was she right or was she wrong? Let me know. You could, feel free. If you like it, great. And I'm going to know that I did something wrong if you bring tomatoes and rotten eggs next time. Okay, so just brief outline. I have to tell you what's going on in the current healthcare system so you can use that as an anchor for what you're going to see in terms of the recommendations on the platforms of the two candidates. Then we'll first look at what could happen and what could happen to healthcare in this country if Donald Trump is elected as our next president, and what could happen if Hillary Clinton is our next president. All right, so when we're starting here looking at national health expenditures, let me get I'm going to focus first on these two lines down here, which are growth rates. And the blue line is the annual growth rate in national health expenditures. Most recent data is sort of at the end of 2014. The new estimates for what happened in 2015 will be coming out this fall. And then this red line here is the growth rate in national, sort of in gross domestic product. And so what you can see in terms of growth of gross domestic product, we had that dip during the Great Recession, and now we're starting to come out of it. Of course, anything out and beyond here is forecasts put out by the federal government. This is done by the Center for Medicare and Medicaid Services. So, the thing that's always disturbing, and the real problem with healthcare, is that the blue line, except for this little brief part here, is always above the red line. So we are constantly having health expenditures growing faster than our economy is. And so that's led to, we're going to have a little bit of a flat period out here in the next 2-3 years in terms of the share of the economy going towards healthcare, but then that's going to rise, predicted to rise to close to, sort of 19.1% of the entire economy in 2024. And so, in a way, with my students, I don't teach many pre-meds. I actually teach undergraduates health economics, and I have 1 or 2 pre-meds, but then the rest of the students show up, and there's a growing percentage of these students who actually end up in the healthcare sector afterwards. And I think a lot of that is not my teaching, it's just sort of where the job opportunities are. And so, in a way you think, oh, that's a good thing, but then you also have to think in terms of opportunity costs and what is this expenditure crowding out? And it's probably crowding out a lot of other things we care about. Okay, so let's break this down and look at where these expenditures are going. Some people don't realize, the bulk of this spending is actually going towards these blue bars here is private health insurance, okay? That's the employer-provided health insurance that most of the people here in this room have. And then green is Medicare and red is Medicaid. All right, and I apologize. I know it's hard for people in the back to see some of these numbers. They get hard to read. So what you see is I've got 2007. Let's look at the difference between 2007 and 2015. If you scrutinize these more closely later on, you'll find that both Medicare and Medicaid in the last 8 years grew by $200 billion each. Okay, so that's already sort of quite a stunning amount, and then given how much we're spending on private health insurance, that actually grew by even more than $200 billion over the last 8 years, and you can see, sort of 9 or 10 years out, we're just destined to be even higher. So growth problems all across the spectrum that need to be dealt with, and this is sort of just another way of showing you these different growth measures, and this was due to the Medicaid expansion, this high red line here, and I'll talk more about the Medicaid expansion in a minute. Okay, so right here is, I just wanted to take a closer look at what is going on in terms of sort of family and employer-provided health insurance, because these data are not always discussed much in the press. Again, a very stark change between 2005 and 2015. The total cost of family insurance, an average family size is 2.5 people these days in the United States, $10,880 in 2005, and it's now all the way up at $17,500. Okay, and that increase has been shared between, this is the portion that the employer pays, and this is the portion that the worker pays. So really, really dramatic changes, and I'm not sure that everyone pays attention to that, because what happens is you elect your health insurance coverage at the start of the year, and you might sort of notice, oh gosh, that number looks large, but then you forget about it, and it's just automatically taken out of your paycheck. And in a way, I wish what we would do is change changed that practice so that every year you had, or every month, you had to make a monthly payment for that premium amount, so you would realize just how large it is and what an effect it's having. Because I think workers should be upset about how much they're having to pay as an increase for health care coverage. And this just shows you sort of another way of if you want to sort of break down those numbers, but sort of in 5-year increments. And what I thought was quite interesting here is the premium increases for 2005 to 2010 and for 2010 to 2015 really haven't changed all that much. Okay, then you want to think of this as sort of, well, 2010 is when we signed the Affordable Care Act into place, and we haven't had much improvement on that side in terms of expenditures. So I'm not going to spend a lot of time talking about prescription drug expenditures in this talk. I think we're working on trying to have another complete event on prescription drugs, but I know it's on many people's minds just because of all the press in terms of Scarelli and hepatitis C drugs and every other thing that's going on. So we've got prescription drug spending here, and you can see this big tick up in 2014. And this is the most recent data, and of course, I'm sure you'd see a bar just as high in 2015. So this has gotten the press and the public extremely upset, and it's become part of the election rhetoric. I just want to put that in perspective, though. If you look at prescription drug expenditures as a portion of all expenditures, the axes, the units are off. So this is like a difference between 9 and 10.5%. But if you look, we started at sort of 10.2% here, and we get out to where we are now, and so prescription drug expenditures are 10% of all of our spending, and they're going to rise a bit, but they're still less than 10.5% of all expenditures, even with all these crazy increases that we've seen. This is what they're expected to end up being. And just take as a contrast hospital care, which takes up, well, less than a third of all of our healthcare costs in 2007, and is destined to become a third of all healthcare costs out in 2024, okay? So I think almost, sort of this distraction of prescription drugs, it just takes us away from some other major problems we have in terms of healthcare spending, and what we're throwing money at, and sort of thinking, where can we find efficiencies and cost savings, and where should we direct our policies? Okay, so now to the insurance side. This is data from the Healthcare Reform Monitoring Survey conducted by the Urban Institute. Now, we conduct a healthcare reform monitoring survey just for Texas. We use the same survey instrument as Urban Institute, but I want to show you the national numbers first that they have. And so prior to the insurance provisions of the Affordable Care Act, you had percent uninsured adults ages 18 to 64. This is about 17.6% of the United States population that was uninsured. Now you've been hearing this, and this has just been coming out in the news lately. 9.9% of all sort of non-elderly adults in this country who are without an uninsurance at this point. So this is the first time we've gone under double digits, and it's a big deal, and that's very exciting. Okay, so there is a difference between states that took the Medicaid expansion under Obamacare, and they're down to 7.3% uninsured, and the ones that have not taken the Medicaid expansion, 14.1%. Texas is a part of this group. I know some of you are not all that familiar with a lot of this healthcare lingo. The Medicaid expansion refers to the fact that for a long time, Medicaid has been terrific. It covers lots of low-income children and pregnant mothers, and the Medicaid expansion as part of Obamacare was to allow low-income adults, either working or not working. A lot of them are at minimum wage, and they're still below the federal poverty level. It's to allow them access to Medicaid insurance. And so that's what's going on in places like California, sort of some of the eastern states, and it's something that many of the southern states have chosen not to participate in. Okay, so where are people getting their health insurance from now? You saw those expenditures for health insurance. 54% of Americans are getting their insurance from employer-provided health insurance. 23.7 are getting it from Medicaid and CHIP, the Children's Health Insurance Program, and that's because of the Medicaid expansion. This slice used to be a lot smaller. And this is the non-group insurance. So this is individuals buying insurance through the state marketplaces, and self-employed people, some of them are actually buying it directly through insurance companies and things like that. But that's that group here, and then we've got, some various other categories here. So, what are we getting for all the money we're spending? And we are spending a lot of money under the Affordable Care Act. What the statistics show you, this is from the Congressional Budget Office for 2016. We're spending $32 billion on premium tax credits. So what happens is most people who buy insurance through the marketplace, through healthcare.gov, they're low income, and they punch in their income on that website, and then they get told that, well, we're going to reduce the cost of your health insurance. Here's going to be the price, and the rest is a tax credit, but that goes directly to the insurance company to help pay for the rest of the cost of the premium. And then in addition to that, other people, sort of the most low-income people, get cost-sharing subsidies. So there are different types of health insurance policies you can buy on the marketplace, and the cheapest policies have the highest deductibles and the highest amount of co-payments. There are low-income people who will get subsidies to pay for those deductibles and co-payments, so that's not too much of a burden out of pocket. I won't talk about this much. Ask me about this later. So the projected cost, all these expenditures is projected to cost $4,240 per person covered. It is expected to rise to 2026 because of those national health expenditure growth rates you saw on the initial slides. This is how this sort of compounds up and starts growing and becoming quite large. But in terms of subsidies and then the projected average, given that the bulk of people are getting, who are buying policies are getting a nice subsidy. This is kind of a decent amount because remember I told you for family coverage, on average employer-sponsored insurance is about $10,500. Okay, so that gives you sort of an idea of how much we're spending in terms of taxpayer dollars to get more people covered with health insurance. Okay, so trends in uninsurance for Texas versus the United States. And so I've got the Texas is in the red bars, the rest of the country is in the blue bars. I did not choose those colors. Brenda actually just sort of chose them out of nowhere. So these blue bars are those numbers that I graphed for you in the previous graph. Those are the national rates of uninsured. And you can see here we are in Texas, and I've got a rate here of about 19 percentage points. And just, this is one of those technical asides. You'll see a lower rate, a slightly lower rate in our most recent issue brief we did, the Episcopal Health Foundation. It's just because these are regression adjusted and those aren't. But the thing in a way, this is terrific. We've lowered our insurance from uninsurance from 26% down to 19%, okay? But the thing I find most disturbing is this rate here, adjusted or regression unadjusted, is higher than the rate that the rest of the country started out before Obamacare's sort of insurance provisions came into play. So this is how much this state has to catch up with the rest of the country and what's going on in terms of insurance coverage. All right, so I've gone through those basics. Now we're ready to talk about the two candidates. It's completely random in terms of which candidate I chose to go first. So if you go to the Donald Trump's website, this is what you'll get on the very first page. And well, actually, Donald Trump's is in a way easier to go through because he has 7 particular recommendations that he posted on his website, which makes it very easy for me to just crank through all these and see what's going on. So we'll talk a little bit about each of these. Repeal Obamacare, open the sale of health insurance across state lines, allow individuals to fully deduct health insurance from their taxes, allow individuals to use health savings accounts, require price transparency for all healthcare providers, block grant Medicaid to the states, and allow consumers access to imported, safe, and dependable drugs from overseas. Let's start with repeal Obamacare. I thought that it's kind of nice. You get onto Google Images and you sort of look for all the different cartoons. So it's actually it's kind of fun to do that. So as you can imagine, there are a lot of people who are in favor of repealing the Affordable Care Act. And so let's go into the numbers part of this issue. What happened was there were members of the Senate who wanted to repeal Obamacare back in 2014, 2015. And so the CBO, which is nonpartisan, was required to do budget calculations of what would happen if the Affordable Care Act was repealed. And lo and behold, so this is back in 2015, this is what they predicted. So this is what would happen to the deficit. And so what it's saying is, let's start with this line up here, the lighter green line. You know, it starts out in the first couple years, the deficit goes down, and then it actually rises. So this is the policy consequences if you got rid of Obamacare and went back to what we had before, okay? And this is without macroeconomic feedback. This is with macroeconomic feedback. This is extremely technical modeling that the CBO does, and they're extremely good economists. What the macroeconomic feedback does is it takes into account that what happens is if you get rid of Obamacare, there are fewer taxes, that money goes back into people's pockets, they use it to spend on other things which boost the economy, and so the deficit doesn't look so bad. But still, this is a positive, very large increase in the deficit. And I'm only talking about the deficit here. I'm not talking about the national economy as a whole. But what people don't realize is in order to get the legislation passed, the administration made everybody at the table pay in. There are taxes on everybody. There are taxes on health insurance policies that get passed on to you and me. There are reductions in Medicare payments to hospitals that go on. There are taxes on prescription drugs. There are taxes on medical devices. And so all that was supposed to be new income to the federal government, plus there are savings in Medicare that are built in. I've talked about that last year, but there's a lot of savings from the Affordable Care Act that are built into Medicare to reduce costs. And so if you repeal the legislation, wholesale, you get rid of all those things as well, which is there are some problems with that. Okay, so it turns out the CBO report says repealing the ACA would also cause 19 million people to lose health insurance, okay? And that's because the subsidies are what gets people to buy in and buy these insurance policies on the marketplace who were previously uninsured. And it also, sort of takes away the Medicaid expansion. And of course, just as equally as many people got covered with the Medicaid expansion so far. You would end up with 48 million total uninsured in 2016 and 50 million uninsured in 2025. That's not to say that we don't have uninsured now. If you look at the numbers now, we still have just under 30 million people uninsured, all right, even with the Affordable Care Act. So that's a work in progress. Okay. You get rid of the law, insurance premiums are actually going to increase, not decrease. One of the main reasons that the premiums are to be held down to the extent that they are is that you have an individual mandate in there which then requires younger, healthier people to come in and buy policies. They get cheaper policies to an extent, and you really want to get all those people into the system. We actually don't have them all in, as many as we would like, and that's why you saw that recent announcement about Blue Cross Blue Shield raising their prices 50 to 60% here in Texas, and we can have a whole other discussion about that. But if you get rid of this mandate, no healthy people who can't be bothered buying insurance coverage are going to be in there. All right, and the other thing about the Affordable Care Act is it did get rid of pre-existing conditions as an excuse to sort of not provide anyone health insurance. You get rid of the Affordable Care Act, then insurance companies are then again allowed to exclude people with pre-existing conditions from coverage. And so this quote I take from Gail Walensky. She was the CMS administrator under Bush 41. Her comment on this: if you repeal the Affordable Care Act, you've got to have a serious way to expand coverage to replace what you have taken away. There's nothing I see in Trump's plan that would do anything more than cover a couple million. Okay, so that's her seat of the pants estimate of what would happen. So another organization, so remember what I just showed you was a CBO estimate from 2015 of repealing Obamacare, okay? But you saw there's a bunch more stuff that Trump also proposed. So the Committee for a Responsible Federal Budget actually did a calculation, an estimate of the entire Trump proposal. That's not something that CBO is allowed to do. They are not allowed to do a cost estimate. So this group, CRFB, did that. They are a credible organization. We've actually had their president come to speak with us here, Maya McGinnis. It's bipartisan, led by a number of extremely prestigious sort of people who have worked on both the Democratic and Republican sides in the past. Okay, so they go ahead and do their estimates of repealing Obamacare, sort of updated now. They say $200 billion extra, okay? So for example, here, you would save $1.12 trillion from not having to spend on all those subsidies and all the other things that we're spending on to cover people with health insurance, but net, over 10 years, you'd spend an extra $200 billion, and we're gonna talk about these things. Allowing insurance to be purchased across state lines only saves you $10 billion. This deduction for individual health insurance, that adds on another $100 billion. You're saying, these people don't have to pay their taxes anymore, and so that's another $100 billion out of the budget. Importation of prescription drugs only saves you $20 billion. So what we're talking about, they're saying under sort of the standard methods of the CBO, Trump's proposal would cost the country an additional $490 billion, and if you wanted to allow in dynamic scoring, which was that macroeconomic effect that I showed you in the previous case, best case scenario, we end up paying $270 billion for Trump's health care plan. So that's where it's standing right now in terms of the policy analysts and what they're saying in this country. I have not seen an estimate or someone contradicting these estimates, although they are fairly new. All right, uninsured almost double under Trump care. This is also from the CRFB. This is what happens as CBO. You repeal Obamacare, and then this comes, you do manage to cover an additional 1.1 million who are able to deduct, because of that additional deduction of their health insurance from their taxes, they'll choose to purchase health insurance when they wouldn't have before. Okay, so this issue, and this comes up a lot during various different debates. Health insurance competition across state lines. So currently health insurance is very state regulated. You're not allowed to, our Blue Cross Blue Shield Texas people aren't allowed to sort of go over and sell their health insurance in Louisiana or Oklahoma. The first study was done back in 2011 by Steve Parente, who's really a top-notch health economist who does a lot of advising for Republican candidates. He was a major healthcare advisor for McCain during his election. But this is not a sort of a Republican, all-Republican type of team that did this, because two of his co-authors, one of them is Jean Abraham. Well, two of them came to speak here at the Baker Institute. Jean Abraham, you remember her coming here last year, and Roger Feldman as well. Jean Abraham was actually on the Council of Economic Advisors working in DC in March 2010 when the Affordable Care Act got passed. So she was part of designing the legislation. Their estimate, national market for health insurance could lower premiums 10 to 20% and cover 5 million more people. Okay, so you get rid of all the state regulations regarding state barriers, and this is what you could do. 5 million, that's not bad. So that's definitely worth considering. You can't do this piecemeal, because what's happened is both Wyoming and Georgia passed legislation to allow out-of-state insurers to come in and sell health insurance in their states. No one entered. Okay, as far as I could tell, sort of there were newspaper reports about this in 2012, and I kept looking subsequently after, and there was no news. So people don't come in, and why is that? It's because it's really expensive for these insurers to try and go into another state, because you actually have to offer people health care, which means you have to go in and negotiate with the hospitals and the physicians to provide coverage, and that's actually a costly exercise. All right, so allowing people to fully deduct premiums. Keep in mind, all these people who already have employer-sponsored coverage, we do get a deduction. Like you see it, that's why you buy your health insurance, through your employer, right? So that you can buy it pre-tax. So we already have that deal, all right? And these are Medicaid and CHIP people, so they are relying on the government to buy their insurance. So this deduction only applies to these people, right? And these people would lose many of them are getting very generous subsidies under the marketplace. If you repeal Obamacare, they lose those subsidies, and you're saying, well, I'm giving them an insurance deduction. A deduction for them to purchase health insurance instead. Okay, but you think of, think of a lot of these people in this group. For example, let's see, federal poverty rate is just under $12,000. Take someone at 150% of the poverty level. So say you're earning $16,000 a year, all right, and you're an individual. Currently, you probably in almost everywhere in the country in the state marketplace, you can get a free bronze health insurance policy, and you would pay a little bit more for a silver policy. You lose that subsidy, you have to go out and say, buy a $4,000 policy? Because that was the average price we were talking about, even if it's a $3,000 policy, all right? And then you get to deduct, at the marginal tax rate there is something like 15%, all right? So you get a 15% discount on that $3,000 policy, best case scenario. Probably most of these people at that income level are not gonna buy health insurance. Okay, so this is just, there will be some people who will get a good deduction. If you're earning a decent income, of course this would make sense. And that's an inequality that we're sort of struggling with in the country right now, something just in general that's wrong with health policy in general. But so, I don't know, $100 billion well spent? I'm not so sure. Okay, and that's just to remind you, the cost of this actually, it is a cost. It would be something the federal government would pay, so it's an additional $100 billion we're talking about. Okay, another proposal on his website, allow individuals to use health savings accounts. Do many people have these? Yeah, I thought it's something I'd love to look at more in terms of our work at the Baker Institute, because I get the impression that it's growing very much here in Houston. I think they're a terrific idea. The government also thought they were a terrific idea, and so if you Google health savings account, federal government or something, you'll find health savings accounts were created in 2003. All right, so this is text taken off of the Treasury's website. So this policy proposal needs more elaboration. We have health savings accounts, okay? I'm sure we could get into discussions about, but there are these regulatory barriers, these problems and things like that, but it is kind of disturbing. They already exist, and there just needs to be more careful, thoughtful discussion of, if you don't like the current HSA policy, what do you not like about it? The other thing I would note is we're talking about affecting different types of people. A health savings account is really for middle-income workers who have a decent amount of money that they could set aside to spend for health care. It's not something that's really going to be something exciting for very low-income workers who are having problems paying for health insurance. All right, I completely support Trump on requiring price transparency from all healthcare providers. This is something that was completely missing from Obamacare, and we should be talking about more. This report came out within the last few months. It's healthcarepricingproject.org. This is the Healthcare Cost Institute, managed to get all of the insurance claims for 28% of everybody with employer-sponsored insurance coverage in the country. So this is about as big a data set as you can get. And you see just sort of various differences. The lowest categories in the United States spend $6,000 average hospital prices, and then the highest categories are spending $14,000 per hospital stay. And this is sort of disease adjusted, so adjusts for the the different complication and severity of the population in these different areas. Now you're going to say, oh yeah, but look at all these light-colored areas. They're places with low costs, so that's what's driving these costs. And so they go ahead and do some more detailed numbers. So they say, let's look at prices for an MRI in Philadelphia, and what you see, these are sort of different providers that they looked at and took all the claims and figured out their average prices for an MRI, and you see they vary by a factor of close to 6. Okay, so that's highly troublesome. We don't get enough information out to consumers, and so the question is, well, if you give this information to consumers, what the heck are they going to do with it? Is it going to matter? Because a lot of them have great coinsurance. They don't care what they're going to pay. Well, another study was done where a number of different people were given access to price data from a company called Castlight, and they compared the people who had access to the data versus not, and amazingly enough, and they had different sort of rates of coinsurance, all right, so they're not paying completely out of pocket. And so things like for laboratory tests, for those who searched, they found prices that were $3.45 lower, advanced imaging close to $125 lower, clinician office visits not as much, and you could see that. If you're going to see your PCP, you don't want to switch just based on some additional price information. You have a standing relationship with that person, you're not going to switch. Okay, I'm going to skip over because I want to give some time to Hillary's platform as well. There was a notion of block grant Medicaid to the states. Just keep in mind what a block grant means is we fix in time how much the federal government is going to give in every state, and then we don't ever change that. We don't adjust for inflation, and we don't adjust for population growth. And that's what has happened with TANF, Temporary Assistance to Needy Families, and what has happened is because of that, we're actually spending much less on welfare per person than we did more than a decade ago. So we can consider a block grant, sure, but it needs to be a different block grant than what we've had from Medicaid. Otherwise, places like Texas are going to suffer because we have a growing population, and we're going to continue to have a growing population, and we're not going to get enough money to pay for new people in Medicaid. Import drugs from overseas. There's questions of risk. The FDA worries about how they can control the quality of drugs. There's concerns about counterfeiting. And then there's also the issue of expenditures, all right? So basically, the problem with allowing reimportation is drug companies make most of their money from the US market. So what are they gonna do if we're trying to go off and get cheaper drugs from elsewhere? They're not gonna lower the prices here. They're gonna raise them elsewhere, okay, because we're such a large part of their market. And because of that, there was a CBO brief, because this issue pops up all the time. It's not just something that Trump has proposed. Many people have proposed it before. And the CBO predicted it would save about 1% per year. Okay, so not so great. Right, so let's go to Hillary Care. I have to do a cartoon here too. So here's where we stand. And this was harder because there weren't numbers, and you go to different pages on the Hillary website and you find different things. So the main things, the three things that she wants everyone to see on the main page are right here. Building on the Affordable Care Act, sort of saying let's clamp down on prescription drug prices, and then protect women's access to reproductive health care. I only have time to sort of really talk mostly about the first one. The second one, yes, we should crack down on drug prices, but as I said before, I really don't think that's the main problem with where we're going in this country in terms of trying to control healthcare costs. Okay, so what does she want to do to the Affordable Care Act to strengthen it? This is what I find disconcerting about this policy proposal. I've explained the tax credits to you and about how people get assistance, and I'll just jump straight to a table on this. Okay, it's actually very complicated to tell you how much assistance you get, all right? Basically, if you get on the healthcare.gov, this formula information is all in the background, and it pretty much says if you are at 100 to 133% of the federal poverty level, we only want you to spend at most 2% of your household income on health insurance coverage, all right? So lower income people should not have to pay as much out of pocket. And then if you're at 300 to 400% of the federal poverty level, you should spend at the most 9.56% of your income on health care. Now, the challenge, though, is this. What happens is Hillary's proposal, if I'll go back, says So you saw that 9.5% on the previous slide. So she's going to cap that at 8.5%. And I assume she's going to lower all those percentages in that table, all right, so people get even more assistance to buy their health insurance. And it's saying no more than that percentage of your income on coverage and out-of-pocket expenses. Okay? So I mentioned before, you buy a health insurance policy, but you still have to pay a fair amount in terms of deductibles and co-pays. Okay? So here's an example of the current amount that you have to pay in terms of deductibles and copays. For those of you who are not too familiar, a bronze plan, those are actuarially calculated so that on average, someone who buys a bronze plan gets 60% of the medical costs paid by the health insurance company, and they pay 40% out of pocket. Silver plan, you pay 30% out of pocket. Gold, you're paying 20% out of pocket, and so on and so forth. Okay, so as you can see, if you buy that, the bronze plans are very cheap. As I said before, you can take the tax credits, and pretty much everywhere in the country you get health insurance coverage for free, but then you're responsible for, say, a $5,000 deductible. Okay, so what the Clinton plan proposes on doing is saying, we're going to make that plan cheaper, and we're going to lower the amount that you have to pay out of pocket. Okay, sounds like a great deal. That's all very nice, but remember, this is taxpayer money. I already told you that the average amount that we're paying for coverage for a person in the plans is over $4,000. And how much more is the country willing to pay? That's up to each particular voter to decide, and it has to do with, it's within the broader context of a debate we're having on health and on income inequality in this country and how we distribute wealth. And so that's up for you to decide. I'm not going to, that's a value judgment, and that's not something I want to be talking about right now. And then another thing that reduces out-of-pocket costs, require insurers and employers to provide up to 3 sick visits to a doctor per year without needing to meet the plan's deductible first. Okay, again, it adds additional costs. And then you have to do a very careful analysis of, does that improve health? I would argue that the existing information that health economists have done through the RAND health insurance experiment would say that there is actually no documented proof of improved health status if you allowed for these 3 additional free visits for people out of the start of the year. Okay, encourage all states to expand Medicaid. I think that's a terrific idea. We can get into another discussion. I think Texas should expand Medicaid, primarily a business decision. It helps our healthcare providers here in the state come up with money that they badly need to take care of people who are showing up at their doorstep, and instead we're sending money to places like California and New York to do this instead. Okay, then just all over the website, and you have to keep bouncing around, and I'll just run through these very quickly. More information on outreach so people know about the marketplace. There's evidence that a lot of people who could enroll in the marketplace don't, or who could get Medicaid don't, just because they don't have enough information and aren't able to access the tools. A lot of people don't have internet access, and so it's really hard to buy an insurance policy if you don't have internet access. Expand access to affordable health care to families regardless of immigration status. That's going to be a hot button. And I'm waiting to see when it comes up in a discussion, and I'm sure it'll come up, on TV sometime this summer. Continue to support a public option under the Affordable Care Act. So if you read the New York Times, there's been discussions about allowing people under age 65 to buy into Medicare and allow that as a competing option. In a way, it sounds attractive at first, but then you realize, there are actually some problems with Medicare, and we'd have to fix those first. So, for example, most people with Medicare also pay for supplemental health insurance through Medicare, all right, and they get money from they use their Social Security check to pay for that, so that's sort of an additional cost, and I don't know how we get that to work, but it takes more thought. The laundry list goes on. Protect Americans from surprise medical bills. Santiago mentioned before, we're working on that here in freestanding emergency departments here in Texas. Enforce and broaden the ACA's transparency provisions, and so, they talk about sort of transparency and coverage provisions and things like that. What I found really interesting is her platform does not mention anything about price transparency. And I think the reason why they do that is they're probably worried about offending doctors and hospitals. So I thought that was an interesting notion. I think price transparency would lower expenditures tremendously in the US, and so I'm all for it. Create a fallback process for states that do not have the authority to modify or block health insurance premium rate increases. And so this is addressed towards this problem of, oh my gosh, Blue Cross Blue Shield raised their prices 50 to 60%. Again, that was due to their healthcare costs being high. And yes, we can get into the sort of legalities of there are sort of insurance regulatory issues at the state level, but I find this is sort of something that's going to be very hard to do unless you want to take all health insurance coverage control out of the control of the state and put it with the federal government, and that creates problems in itself. Vigorously enforce antitrust laws to scrutinize mergers and ensure they do not harm consumers. We've had speakers come here recently over the past several years from the economists who've served on Department of Justice and the FTC, talking about healthcare mergers. I think they've done a good job. I think we want to keep that up, but I don't think it's something that we need to be saying is not being done at the moment. Shift from fee-for-service system to a value-driven care. I do agree that this is probably one of the most important things we can do to control growth in Medicare costs and eventually move these types of strategies over to the private sector, although the private sector has been very good at coming up with some of these value-driven care proposals on their own. So it's not as if the federal government has to really get involved. We've got a paper coming out in August talking about a shared savings approach that we studied that Cigna employed on their own without any encouragement from the federal government that led to a substantial drop in healthcare expenditures. So even though I think it's very important, I find it interesting that this is at the bottom of all the different proposals. And I think it's partly because it's very hard to understand and it doesn't get people all riled up and going to the polls to vote. Aggressively rule out fraud and abuse. We're working on that all the time, I think, in terms of the federal government. Expand access to high-quality data to improve the efficiency of healthcare. That also is going on in healthcare, and I think there's probably people in the room who know more about this than I do. So it's certainly happening at the TMC. And leverage public and private resources for entrepreneurship that improves healthiness and security. Again, I don't know. I'm sorry. It's a platitude. Okay, so I want to give some time for questions. How does one make sense of the competing platforms, and what's the bang for the buck? So essentially, it's like, what do you think? Usually, I have concluding remarks, and I just put it all up there in sentences, and you can read. So I'm going to make you work. I'm actually not going to spell it out, and I'm going to put everything in graphical form. So economists like to think, what's the bang for the buck in terms of intervention? Okay, so we usually think in cost-benefit analyses, all right? So this is what we've got right now, and if we adopt a new intervention, how much additional cost would it be, and what would be the additional benefit? Okay. So let me give you an example here. You can find this if you go on the website. It turns out daily aspirin for people, middle-aged men with Barrett's esophagus, lowers costs because the aspirin is really cheap, and people with Barrett's esophagus are at risk of developing esophageal cancer. So what you do is you give them aspirin now, that lowers their chance of getting cancer in the future, and so that saves on all those costs of cancer care. Okay, so lower cost and better health benefit. Definitely should do that. So here's an example of something that's higher cost and worse health benefit. Another study, I guess, for people who have blood clots, sort of lung blood clots, and have right ventricle dysfunction, and some doctor's going to say, tell me, you're all wrong. But currently they get heparin, and so this study was looking at what if you added TPA onto that, and they found out that it was more costly and it killed more people. So definitely don't want to do that, right? Okay, and so this is something that we've had from before. Before we had kidney dialysis, sort of we decided, should we pay for this technology or not? It's expensive, and as you know, sort of as a country, we do pay for kidney dialysis for patients with end-stage renal disease through Medicare. So we've decided that is more costly, but we think the health benefits are enough that we're going to support that. Okay, so let's put this to the test in terms of healthcare platforms. Oh, by the way, down here, you could think of cases where you might want to do this. You would have a loss in health benefit, but you would also have a drop in costs, okay? So if something led to a very small drop in health benefit, but a big savings in costs, there might be cases when you would want to do that. So this is my wrap-up, okay? Judging from what I could tell from the numbers, I would say, and this all depends on what you choose on the axes. So you could choose different things on the axes and you would come up with a different conclusion. And I'd love to hear your opinions on that. I'm putting net federal spending up here. I'm not putting the entire country's spending. I'm not putting, your out-of-pocket spending up here. I'm just sort of saying this is the consequence of the federal government because that's what the CBO has been doing. Those are the numbers I've showed you. And this is access to health care. So I'm saying we've had an overall moderate increase in net federal spending because remember, the Affordable Care Act, as it was legislated, was designed to be budget neutral. And so I'm sort of saying, well, let's not put it right down at zero in terms of cost. Let's assume it actually ended up costing us something. And we've had a good increase in access to health care. We've got 20 million more people covered with insurance. We're still left with 30 million uninsured. Hopefully we can get that down. We'll see. All right. So Clinton, because of all, what I'm really concerned about is all of these different proposals to increase subsidies, increase tax credits, control prescription drug prices, and all these other things are actually going to drive up costs a lot, and I'm not convinced that they're going to improve insurance coverage all that much. And unfortunately, I think there are some other really good qualities about Donald Trump, but in his healthcare platform, you saw the numbers. They've been sort of crunched out by experts, and there is a drop in insurance coverage and an increase in costs that goes in there as well. Okay? So that's where I think they are. Feel free to disagree with me. I'd love to hear people's different viewpoints on these things. And I will stop for here. Hopefully we have some questions. And we are recording this, so there are people with mics, and they're going to come around. So please don't ask a question until you get a microphone. Oh, yeah. And you can also give a card to me or Brenda or Mara, and we can email you the slides.
Hi, Vivian. I'm Cedric Dark from Baylor College of Medicine. Thank you for your presentation. I just had a question. Where would you throw Bernie Sanders on your graph?
I didn't say I was going to do that. So has he been all that specific? He has not been as specific. The thing is, I don't think he's been more specific on other policies in terms of what he wants to do in terms of college tuition and in terms of tax rates. I don't think he's a fan of the Affordable Care Act. And so can I just assume he's going to say national health insurance? Yes. Nationalized health insurance? Okay. Well, of course, you go way out here, but there's a question of how good that health care is. I have to say there is, even though, and I think I sort of talked about this during our last discussion of the political, the candidates during the primaries. Okay, so I've lived and worked in Canada. That's a terrific healthcare system in many, many ways, okay? And in terms of equality, I do think it's better because on average they are healthier, and there are many other developed countries that have longer life expectancy and better access to primary care and all that. I don't think Americans want it, though, because if you go where I was at McGill in Montreal. Montreal has some very good providers, so does Toronto. They do not have an MD Anderson. They do not have a Texas Heart Institute. They do not have a Methodist. They do not have a CHI St. Luke's or a Memorial Hermann Health System, okay? So Americans don't want that. And so that's why, I don't talk about that. And so this question of access to health care, yes, it's terrific for a certain portion of the population. Another portion of the population is going to lose what they they had the money and were willing to pay for, and so that's troublesome. And in terms of costs, yeah, you could argue that it's going to be lower in terms of cost because we're going to cap prices. Okay? I'm really worried about how it would destabilize the system. I think one of your colleagues at Baylor College of Medicine said this best to me many years ago. He said, we're not going to have national health insurance coverage in this country until the doctors ask for it. We get to that point, we'll have it. But we're going to have a lot of people uninsured for a long period of time for doctors to want that.
Yes, thank you for your presentation. I have a question in terms of women's health care with the Affordable Care Act. I know that there has been improvement, especially with prenatal care, and I'm wondering if the prenatal care has decreased infant mortality in this country, if there's any statistics on that, and improved weight of newborns as well.
Yeah, that's a very interesting question. So it takes a while for this data to actually come out and for economists and other health services researchers to have access to it. So I think we're going to have to wait a good 3 or 4 years before we find out that information. The hard thing is when everybody gets access to the additional policy all at the same time. But the beauty of what's going on, for example, with the Medicaid expansion, some of that affects reproductive health, not all of it because it's adults, but a lot of it is child-related. But I think you could get enough variation across states in terms of both that Medicaid expansion, sort of the intricacies of how it's affecting women in prenatal care, but also in terms of the variation across states in how many people are getting covered. So when you look at Texas, we're still getting fewer people covered. So you can get something. It's just going to be really hard to do that study. It's going to take a while.
Yes, thank you for your presentation. I have a quick question. As I look at the continuous delay for the Cadillac tax, I guess my question is going to be, if that kicks in, there's going to be a large number of employees who are going to have much higher deductible, and as a result of that are going to be doing a lot of shopping on the market. Do you think that's going to have an impact in driving costs down and raising competition for a market in which is, for the most part, for many people, if you've got a deductible of, say, $10,000, for the most part, you're really self-insured for a large portion of your expenses that you're going to incur that year. And I'm wondering if you think that will actually drive, if it will, number one, if it will ever stop being delayed, and will it be implemented by either one of these candidates? And number two, do you think it will have an impact as far as driving down costs due to competition?
Right. So that's a very interesting question. I'm glad you asked it. So economists of all political stripes are actually in favor of the Cadillac tax. We believe it's a blunt instrument, but it's the best possible way to enforce costs on consumers. If you require consumers to bear a higher portion of costs, they're going to be more price sensitive in terms of the healthcare providers they choose to go to. And yeah, it's our, who knows whether it's going to be delayed even further or not. Certainly the public is not in favor because it's a wonderful tax benefit. And but I don't think it's going to get as far as you said, for a couple of reasons. So, even though I showed employer costs for health insurance rising, the amazing thing is that employers have been terrific in terms of coming up with health savings accounts and other things to sort of put more of the burden on consumers. So if they hadn't done that and shifted more, moved to higher deductibles and higher co-payments, for drugs, we would have had even higher healthcare cost growth. And that's not the federal government. That's just employers acting, maybe in response to the Cadillac tax. The Cadillac tax is not getting so high, even if it does go forward, it's not going to get so high that it's going to push people off of their employer-provided health insurance, simply because that tax benefit in terms of the amount of deduction that the employee can take and that the firm doesn't have to pay in payroll taxes is so high that they're going to stay with what's called ESI, for short, employer-sponsored insurance. So that I don't think is a problem. There are a bunch of sort of really sort of liberal-minded economists who think, oh, we would love that to happen, because if we get everybody onto the marketplace, then we have universal health insurance. And so that's why a number of conservatives are really worried about that policy, and I fully understand that.
Question. Our educational system is more expensive than a lot of other countries. And given what's happening with the population aging, even if you keep the prices the same for healthcare, because the population is aging, you're going to have more sick people, more healthcare costs, more things building into it. And yet, it strikes me that a large number of the public are pretty upset with the cost of medical care at this point, and it's pretty hard to figure out what the correct cost should be, or what percentage of GDP it should be, et cetera. Do you have any comments about where we're going with this? Because I think the costs have to go up unless you dramatically decrease the services.
Yeah, so General, where are we going in terms of direction of healthcare costs?
Well, the costs have to go up because we have older people, they're going to be sicker.
Right, and you saw the numbers I was showing. It's going to go up to 19.1% of the entire economy in another 9 years. To me, that's very disconcerting because, I've seen CBO presentations that say, okay, they talk about the portion the federal government is spending and say, okay, in order for Medicare and Medicaid to go up by the amount we have legislated, here's where we're going to cut. And they are going to cut in education, they are going to cut in defense, and they are going to cut in transportation. And so, these are the things we're giving up because of this. The thing I think most about is really health insurance access is a healthcare cost problem. People would not have problems buying health insurance if healthcare wasn't so expensive. So constantly, I don't know how to fight this in general, but I don't think people are upset enough at hospitals and doctors who are charging too much, okay? And I'm not saying all of them are, because there's a lot of terrific providers at the Texas Medical Center. I will also tell you, though, I hear anecdotes of a lot of waste going on across the street. Okay, and I don't understand why the public gets so angry at insurance companies. Yeah, they should. And they should get mad at drug companies. But no one ever says, doggone it, that hospital is ripping me off. Some do, it's come across. But if there was really the largest increases that I've shown you and the largest portion of our expenditures are on hospital care. And that's where we have to move. Medicare is slowly moving in that way. Whether they're going to be able to move enough to get that 19.1% down more is the big question.
Hi, I'm Gail Abrams. I work for General Electric, but I'll be joining the Master of Global Affairs class in the fall, so I'm excited.
Oh, great.
Thank you. My question is maybe a little bit loaded, but back to the graph. Is there one or two or three things that you really think that could get us from the yellow down to the green and actually reduce costs?
Oh, getting down to the green.
Yeah.
So strangely enough, the stuff that I thought was at the bottom of Clinton's page, everything about value-driven care, bundled payments, accountable care organizations, stuff that's the dry stuff that's built into the Affordable Care Act that hospitals and providers are struggling with right now. This is not easy, all right, because it requires excellent top-notch management, and sometimes healthcare providers don't have those management skills. That actually could help us. The other thing, though, which is a tougher discussion, is having to do with talking about the cost-effectiveness of certain things, for example, end-of-life care. Okay, so when Obamacare was under discussion in the first place, we talked about there was going to be more information. PCORI, I forget what it stands for, but they're getting hundreds of $millions to do medical studies. They wanted to do cost-effectiveness analyses, and everyone said, oh, hell no, you're trying to kill my grandmother, right? We have to be willing to have honest discussions on some of these things because, right now I'm reading Atul Gawande's book, Being Mortal, and it's such a moving book, and you realize, oh goodness, there are things that we're throwing money at that actually have no benefit and actually harm people, all right? And so there needs to be more discussion. I don't know how we get over the sort of Rush Limbaugh rhetoric to actually have those discussions and sort of talk about technologies that really are extremely expensive and not worth paying for. That could get us to the green, but it's, again, there are political barriers to that.
Mentioning hospital costs, and I had a hip replacement last summer at a hospital that will remain nameless, and I was amazed at the size of the private room I was in for 2 days, and then my last day was Saturday, so they moved me up to the new floor because they were consolidating patients. The room was even bigger, and I'm thinking, okay, how much is this costing? Actually not me, because at that point I was an Exxon annuitant, but Exxon to pay for this space. And the same sort of thing is happening with universities. They build these huge expensive buildings that aren't really necessary to learn.
You're absolutely right. I'm not going to argue with that, because I sit there and I go, oh my gosh, waste in healthcare. And it's like, oh gosh, waste in higher education. Yeah, and I think Rice is just as guilty as many other top-level universities in the country. But so let's focus on healthcare before I get pulled off the platform by higher administration. So this is all this problem of people having very generous health insurance. So I guess you had very generous health insurance. They knew you weren't gonna have to pay for it, and so they pass it on to your health insurer, and this is why your health insurer therefore raises the prices. So this is why I'm in favor of health savings accounts and high deductible health plans, because and I just wish there were policies that allowed you to have a trade-off, not a strict HMO, okay? But something that kind of came to you and said, oh, in these particular cases, would you be willing to take the smaller hospital room and we'll charge you sort of $20 less in premiums per month? Okay, and so there are other ways to build in flexibility in insurance companies. I don't think there's enough flexibility, and I think, for example, employers just sort of say, oh, give everybody really good health insurance because that attracts good workers, and then they don't allow enough selection within the company. I would like to be able to shop for the lower-priced insurance company within my employer. Some employers are doing this because they're offering private exchanges. I think that's a terrific idea. So I hope that gets here. It's a question of whether we get there fast enough. I think I have time for one more question.
Hi, Vivian. Susan Harris from Baker Hostetler. And my question to you goes back to the comment about the private companies moving towards value-based healthcare. And my question really has to do with whether or not you think they would have moved as quickly, or we as a country would have moved or be moving so quickly towards value-based options had not we passed the Affordable Care Act.
So Susan is one of the best health lawyers in all of Houston. So I wish you could answer this question for me. Because, that's a really good point. I am not so sure. On the one hand, I think they realized the costs were getting out of control, and there were employers that were coming to them, and they were saying, yes, the prices are getting too high, we have to do something about this, find us a solution. Okay, but on the other hand, some of this, when I was working with Cigna, I realized a lot of it was because they were hearing from healthcare researchers, at Harvard and other places, who were designing these policies for the federal government as part of the Affordable Care Act. So part of it was a learning process. They didn't know it's like, oh God, I didn't realize what shared savings was, and it's like, we could try this. So there's all these new inventive models that came out just because, that was one nice thing. The Obama administration went to a bunch of nerds and said, what would you do? A lot of people would say that's a bad thing instead of asking a bunch of nerds, what would you do? Because certainly it hasn't turned out perfect. But in that sense, I would think you would be right that Obamacare did move this along faster. It's close to 1:15. It is not raining outside. Again, thank you so much for coming. Please do email us. We'll get a copy of the slides. We'll actually have this up on the web recorded. And love to hear your comments. We do have a written survey, and please do take the time to fill those out. If you couldn't see the slides, write that in, because I think maybe we can use that to lobby for a better projector next time. Thanks so much. Have a good summer.